host disabled attendee screen sharing.
Civitor, it won't let me do it because you're the main host. So you gotta give him the ability to share stuff. Oh, wait a second, hold on. Never mind, I can do it. Okay, now go.
All right, let's see. Can y'all see that?
Yes.
Cool.
Hi, Katie.
All right. So tonight we're talking about pelvic trauma. So to talk about pelvic trauma, we first have to talk about what the pelvis is, obviously. And most people know. So the pelvis is kind of the lower part of your torso. If y'all can see my cursor here, it's kind of the what we think of as the hips. And when we talk about pelvic fractures, we're talking about a fracture in any of these bones, kind of in this ring here that forms the hips. And as you can see in this picture on the left, the pelvis has a lot of vasculature, blood flow, and lots of blood vessels. So any kind of injuries in this area can be really, really bad. As far as the pelvic anatomy that we need to know, the important thing to remember, first of all, is that there's a lot of blood vessels. So your femoral arteries in your legs have to get their blood flow from somewhere, which comes from the body's systemic circulation with the aorta. So blood starts in the aorta, it flows through the iliac artery and goes to the femoral artery. And then venous blood returning to the heart goes through the femoral vein to the iliac vein to the inferior vena cava. So there's a lot going on as far as vasculature and blood movement in this area. So it can be very, very bad if these bones break and nick any of the vasculature. As far as the bones here, we're talking about the two main kind of hip bones that we think of are the iliac bones, or ilium is the singular word for them. And then the sacrum here is kind of the base of your spine. So when you talk about your sacral vertebrae, they're fused here together in the base of your spine, and that's part of the pelvis. And then also the femurs, when they, the top leg bones, when they join to the body, they join into the femur, or excuse me, into the pelvis. And these kind of protrusions on the outside of the femur are called the greater trochanters. And you'll see why it's important to know that later. So the different things that can cause pelvic trauma. So most of the time with pelvic trauma, the cause is typically a blunt force injury. So that's going to be, in our cases, oftentimes that'll be a motor vehicle collision, especially if a pedestrian is hit by a motor vehicle. If you think about most cars and kind of the level that the bumpers and main parts of the car are, it's extremely likely that if you did get hit by a car, you would suffer injuries to your pelvic area, just based on the height that you stand and where the bumper is and other parts of the car, the hood of the car. But they certainly can happen with ejections from cars and other vehicular injuries. And then also, if people have kind of crush injuries, or if something falls on them, something big and heavy falls on them, that can damage the pelvis. And then also falls. So if you fall from a big height, think about, even if you land on your feet, that force can get transferred through your bones and stop there at the pelvis. And then also elderly patients who have more fragile bones, if they fall even from a standing position, they can fracture the pelvis. So it's always important to keep that in mind. The pelvis is a fairly strong bone, so anything that will damage the pelvis will often damage other parts of the body, and vice versa. If you have a large enough force to cause significant injuries to say, for example, the chest, there's probably a good likelihood that the pelvis is also injured. So this figure down here, 10% of blunt trauma patients that end up at a level 1 trauma center have a pelvic fracture. Meaning, if we take 10 patients to MedStar or something, chances are at least one of them has a pelvic fracture. So it's important to remember the fact that the pelvis can get injured in these gnarly, gruesome types of big trauma calls that we run, like car wrecks. And it's often an afterthought. People always think about the chest and stabilizing the spine, tourniqueting extremities, but it's very important to remember how bad a pelvic injury can be and how important it is to identify it. And you can't identify it if you don't think about it. So we should always be considering the possibility of a pelvic injury.
Hey, Andrew, before we go further, can we, if you're not talking and you're not Andrew, mute your system. It's messing everybody else up. Thanks.
All right. So with the injuries that will cause, like I said before, the injuries that will cause pelvic fractures will often cause other injuries. 63% of patients who have pelvic fractures also have trauma to the chest. 50% have long bone fractures, 40% have head injuries and visceral organ injuries like your spleen, liver, things like that. 14% have spinal injuries. Remember that part of the pelvis includes the sacral area of the spine, and so force can easily get transmitted up the spine, or that part of the spine can have injury. And then gastrointestinal genitourinary injuries can present 6 to 15% of the time. And then open fractures of long bones will present about 5% of the time somebody has a pelvic fracture. And this is important to recognize because if you look at this top figure, chest trauma, 63%, the chest is very important for our survival. We have our heart, our lungs, our kidneys, liver, very important organs. So we think about chest injuries as being very serious injuries. And the problem is that if we're too concerned or too tunnel visioned on a chest injury, we could miss a pelvic injury. And as we talked about before, the amount of blood vessels that run through the pelvis can mean that if you miss a pelvic injury and don't stabilize it, and then that injury gets worse and bleeding gets bad, that patient can definitely die from that. So always remember on these multi-systems trauma patients, do not forget to assess the pelvis. So the different ways the pelvis can be injured, and it's more than these three, but these are kind of the three major ways. You have lateral compression, which is like an impact from the side. So think about if you're crossing the street and a car hits you on the side of your pelvis. And AP stands for anterior posterior compression, and that's an injury from the front. So if you're laying down working under a car and it falls on you, that could cause that type of injury, or if you get hit head on by a car. And then vertical shear often happens with falls, because if you remember from like EMT class or anatomy class or whatever, the femur is one of the strongest, if not the strongest bone in the body. So force can be transmitted up that bone without breaking the femur, and it'll go to the next kind of link in the chain, which is the pelvis. And the pelvis is not really designed to take vertical, upward force like that. And you can actually shear off one of these iliac wings, and that can do significant damage to all of the blood vessels and the bones and everything. So as we talked about before, pelvic fractures are serious, but just to give you an idea for how serious, stable pelvic fractures. So a pelvic fracture where the patient is hemodynamically stable when they present, meaning they're not hypotensive, they're not tachycardic, they're not in shock, they still have up to 19% mortality. And unstable patients with pelvic fractures, patients who are in shock, they're going to have up to 40% mortality. So again, just to show this picture here, if you look at all these blood vessels, can you imagine if something were to cause a laceration to any of these? you can have significant bleeding. And due to the fact that there's kind of a lot of open space in this area, you can bleed into the pelvis. You can lose almost all of your blood volume before there's even outward signs like bruising or distension. So it's very important to think about the pelvis as something that can be injured and something that needs to be assessed. Now, this is kind of like a simplified analogy here, but if you picture this balloon on this bed of nails, the balloon kind of represents an artery or a vein, and these nails represent bone fragments. So when a bone breaks, it'll break in a jagged manner. So each one of those edges can possibly cut the vasculature there, and once that's cut, there's almost no way to stop that bleeding, and the patient is at a very, very high risk of dying. So when we do run across these patients, and again, normally this is your falls, your car wrecks, things like that, we're going to go ahead and kind of go through our March algorithm, which is for all trauma patients. So the first thing we do is stop massive extremity hemorrhage. A pelvic fracture is less important if you're bleeding arterially from an extremity. So we're going to, put tourniquets on if they need them, things like that. We'll go into airway and respirations, and then at that point, we can incorporate C-spine and spinal stabilization. After that, kind of our major life threats that we need to address immediately are out of the way. So we're going to go ahead and do our physical exam. Once you have identified, and this is kind of just like a little plug for some of my pet peeves, this isn't exactly specific to pelvic trauma, but once you've identified that this is a serious trauma patient, the first thing you need to do is completely remove all their clothing. This is not the time for modesty. You want to see their entire body so that you know where any injuries are, any bruising, any signs. You can't treat an injury that you can't see. So you need to remove their clothing and assess them. And then you also need to crank the heat up in the back of the unit. If you think about what shock will do, when you lose blood, you go into shock, and shock is a state of lower perfusion in your body. So you're going to be producing less body heat. And what that will do is that will reduce your blood's ability to clot, and it will also lower the pH of your blood. That again worsens your ability for it to clot. So with a trauma patient like this, you should be sweating. You should have the heat up at full blast. So as far as assessment, particularly for pelvic trauma patients, once you've cut their clothes off, you're going to be assessing for rectal or vaginal bleeding. What that can indicate is that there's some type of vascular injury. Blood at the urethral meatus and scrotal or perineal hematoma, again, are signs of bleeding in that area. Any kind of bruising, ecchymosis, anything in that area means that, again, there's bleeding inside. You're also going to want to assess the abdomen just due to the proximity. Oftentimes you'll see abdominal injuries. So you're going to check the abdomen for rigidity, and then also, your normal signs of any kind of problems in the abdomen. Your Cullen sign, Gray Turner sign, which are specific bruises. So Cullen sign is a bruise around the umbilical area. Gray Turner sign is a bruise around the flanks. You're going to palpate all the quadrants of the abdomen just to assess whether anything's going on in there. And then the other important thing to do is to perform a neurovascular exam on the lower limbs. So you want to know if the patient is perfusing their legs. So you want to check cap refill. You want to see if they can move their toes, see if they can feel you touching their toes, and you want to look at their legs. Don't forget the femur fracture just because there's an unstable pelvis or whatever. So definitely keep that in mind. As far as specifically assessing the pelvis itself, what you're going to do is you're going to place your hands on the iliac crest, and as we talked about before, they're kind of the wings, so to speak, of the pelvic ring, and you're going to press inward, so toward the midline of the body. If the pelvis moves under your hands, keep your hands where they're at. You don't want to release and then push again. You don't want to do anything. It's just like splinting any other bone. You manually stabilize it as your first step. So you're going to press inward and hold it there. And then you're going to keep holding until the pelvic binder's in place, if there is any movement. Most of us have been taught in EMT class that you push in and then you push down. The literature actually shows that it doesn't really serve any purpose if they do have like an open book pelvic fracture or any kind of significant pelvic fracture. You will feel the wings move in. So pushing down doesn't really do anything, and all it's doing is increasing the chance that you're going to nick a vein or an artery with those bone fragments. So if you think about it, the pelvic bone is kind of shaped like a ring. So pressing in is kind of putting it into anatomical position where it naturally would be, whereas pushing down is almost like opening the book even further. If you picture a book that's open, it's splitting it open even further, and that can exacerbate injury. So it is a controversial opinion, but my recommendation, and this is supported by a lot of experts and a lot of studies, is that there's no real reason to push down. You're going to do this once. This is not something where, you got the EMT student riding with you and say, hey man, check this out. It's not the kind of thing where you want to release and then resume pressure, because again, consider these broken bone fragments like, sharp nails or pins or knives or whatever you need to do to think about it. They can cut any of these blood vessels. There's a lot of blood vessels in there, and if they cut them, the patient's likely going to deteriorate significantly. And again, once you start this pressure, don't release the pressure until you have the binder on. Now, pelvic binder indications are, so, obviously if they have an unstable pelvis on exam, you're going to go ahead and put a binder on. But, kind of just to give you a little bit more guidelines, if you have a blunt trauma patient that has, obviously a known or suspected pelvic fracture, you're going to put a binder on, or an abnormal exam, but also just pelvic pain on exam, you could certainly put a binder on them. And then also blood at the urethral meatus or vaginal bleeding, and also rectal bleeding. The other thing is, and my personal opinion is that we underutilize pelvic binders. And I think that, you would not be wrong to kind of empirically put one on any blunt trauma patient that has a significant mechanism of injury. It's not going to hurt if they don't have a pelvic fracture, because all it's doing is stabilizing that bone. But it can certainly help. And then this includes blunt trauma cardiac arrest patients. If part of a trauma code should be on a blunt trauma arrest patient should be to put a pelvic binder on. So what it's doing, as we talked about before, is it's kind of stabilizing that ring. What it's doing mostly is keeping those bones from moving around and causing more damage to the blood vessels. There's a little bit of evidence that says that the binder might help to control bleeding that's already going on. Basically, the idea behind that is that when blood is pouring into the abdominal cavity, the pressure of the blood inside that cavity has to be higher than or equal to the pressure that's in the blood vessels before that fluid will reach an equilibrium and stop bleeding into the area. Most of the time, the amount of fluid that needs to bleed into that area will be high enough that it's most of their blood volume, and they'll be in irreversible shock at that point. But the pelvic binder can help to control bleeding in some cases, so it's certainly worth trying, but it's not like putting a tourniquet on. So here's some kind of simplified little views here. Picture this, the normal pelvis here. Picture the opening that's kind of toward the front here as the front of the patient. And then if you look at this normal pelvis, it kind of forms a solid ring. The broken pelvis, one of the wings is kind of sheared off and the ring is opened up. And then when you put that binder in place, it kind of makes a nice little wrap around it and keeps everything tight and stable. So this is an X-ray here. This is an anterior view X-ray of the pelvis. And if you look at these two pubic bones, you just note the big separation between the two. This is not normal. There's a fracture over here. You can see kind of subtly on the right side, kind of where the ilium joins the sacrum. But what's happening is that ring is no longer intact, and so the pelvis is split outward, and this can certainly be a very bad kind of sentence for the patient. So what happened with this patient is actually in this facility, they took this x-ray and then they put a pelvic binder on, and this is the same exact patient, but this is a CT scan, so it's kind of a like a transverse view. It's like a cross section type of view. You can actually see the springs and the mechanism of the pelvic binder up here at the very top. But if you look in this white circle, you can see those two bones that we showed earlier. If you note the distance between them, if you look at this CT, they're closed up, and they're, the position where they're at is now normal. So this is another CT scan of a pelvic fracture before and after a pelvic binder has been placed. As you can see, this is a kind of low resolution image here, but as you can see, the wings here are kind of flayed open, and by putting that binder on, it gets everything nice and tight. So the way that we're going to apply the pelvic binder generally is in conjunction with the backboard. Most of these patients, again, are high priority multi-systems trauma patients that are going to get backboarded. So the best way to kind of knock two birds out with one stone and move the patient as minimally as possible is to stage the pelvic binder on the backboard. So the way you're going to do that is by opening the pelvic binder up and placing it on the backboard. And then when you do introduce the backboard into position, when the patient gets rolled back down onto the backboard, the pelvic binder is right there under them. And all you have to do is kind of close it up, wrap it around them, and tighten, and you're good to go. If you remember before, where the greater trochanters are, which is kind of these the very tops, the outward protrusions of the femurs, that's the level that you want to place the pelvic binder. You're not placing it up too high on the ring, on the wings here. The reason for that is because tightening that can actually make the fracture worse, and you want to stabilize kind of the base of this ring, and that will be the most stable position for that device to be. So it's a pretty common mistake to place the binder too high, but just keep in mind where it needs to be. This video here shows the application of it. Just as a preface, the technique they use is not correct entirely. Their technique is not using a backboard, and what I'll show you here. What they're doing, let's see, I might have to open this in a new tab. Oh no, there we go. So what they're doing here is they're unrolling the pelvic binder. This guy's gonna, oh, this is another good point here. You don't want to apply it over any solid objects in the clothing, like a phone in the pocket. But remember, most of these patients are going to have their clothes cut off anyway. Now, he's feeling for the greater trochanters, which are the landmarks for where you're going to want to put that pelvic binder. Now, this technique of lifting the patient up and sliding it under is not correct. He's kind of going to drop his ass in this guy's face and lift him up. But that's not the way to do it. We want to put this on a backboard so that everything kind of moves, smoothly and fluidly without compromising moving the patient too much and risking compromising the spine. But now we're at this point, picture that the patient is on a backboard now. You have this pelvic binder in the correct position, and the way that they tighten it is by feeding and this is, by the way, this is the same pelvic sling that we use.
Check the other shelves.
What was that, Jamie?
Oh, I'm sorry. I wasn't muted. I was yelling at my
Oh,
husband.
okay. No problem.
Hey, Andrew, so the way you're saying this, we backboard him, so do the patient roll and all that and get him onto the backboard before we actually secure the pelvis. Is that what you're saying?
So that's correct, but keep in mind that the pelvis is going to have manual stabilization at this point. So it's still going to be stabilized. It's just that it's not, you don't want to move that patient too many times. And so by putting it on the pelvic binder, or putting the pelvic binder on the backboard, lets you do it in one movement, if that makes sense.
It does, but it's also requiring 4 or more people now. So we have
Yes,
manpower.
it
So
will. So, and I'll get into the other technique here, but if you like down here on the right side, the alternative to it is to, similar to some of the other ways that like putting like the KED straps under somebody's legs. What you can do is you can open the pelvic binder up, place it kind of under their, like under the void space in their knees or under their legs if you can lift their legs up, and then saw it back and forth, moving your way up to get it into place. So that's another option if you have limited manpower, or if you're trying to get the pelvis stabilized before you move the patient and you don't have the number of people to have somebody manually stabilizing it. So there's a few options here, but the technique here where the patient's on the backboard and the pelvic binder is positioned underneath them is by far the most common way to do it. So, and that's the one way that they specifically say to do if possible in the protocols. So once we have this pelvic binder in place under the patient's hips, we're going to fold the sides up, and then we're going to lace the strap through the buckle. One person's going to hold the one side, and the other person is going to pull the strap. And the way this works is that this device is spring loaded, and there's two little prongs that will come out once you've reached the proper tension. And at that point, you can secure the device back down. And we'll talk about that in the next slide. So the closer view of the mechanism here shows you that, if you can see that, as soon as this strap gets tight enough, the strap will kind of pop, and you'll hear it actually. It makes a click, and then two little nubs will come out here. They don't have to stay locked in these holes, but all that's telling you is that you've pulled enough pressure on this buckle to where it's an adequate amount of pressure to stabilize the pelvis. So you don't want to pull it, let it go till it pops, and then reduce the pressure. At that point, you want to maintain this consistent level of pressure, and then you're going to Velcro the end of that strap down to the device. So once you have the device on, you're going to obviously just reassess the patient like after any intervention. You're going to want to double check the distal like pulse motor sensory. So that's going to be, same as if you splint any other part of the body. And then just continue managing the patient. Oftentimes, the pelvic binder will definitely help a fairly significant level to reduce the patient's pain. Keep in mind that along those arteries and veins, there's a lot of nerves. So any kind of injury in that area will be extremely painful. And by putting a pelvic binder on, you can significantly reduce their pain. So here's some special circumstances that you might happen to see. Probably the most common one is a femur fracture in conjunction with a pelvic fracture. And what you should do in that situation is continue to apply the pelvic binder just like you normally would, but you're not going to want to use a traction splint. What that's doing is, yes, it is pulling the femur into place, but you can actually cause more damage to the pelvis. So you're not going to want to use a traction splint, but you can use a backboard to support that whole limb and keep that whole limb from moving. Pediatric patients. Pelvic fractures are pretty uncommon in kids because they have more flexible bones. So most of the time there's not, you won't see a pelvic fracture. But if you do, the pelvic binders that we carry might be too large to fit. So you might have to improvise something with like a bed sheet, tying it tight. This presentation doesn't talk about improvised pelvic binders because we fortunately have access to the commercial devices. but I think most of us learned in EMT school the simple ways where you can tie up a bed sheet or something to secure the pelvis. And then also keep in mind that they might need less pressure than an adult would. A pregnant patient, if you do have a pregnant patient, you're going to just put a pelvic binder on like you normally would. Pregnancy is not a contraindication. And then with blunt traumatic cardiac arrest, most of the time these patients will be priority fours or non-viable patients on our arrival. But in the off chance that you do end up having a blunt trauma working code, you're going to want to prioritize, not above some of your other things, but certainly you're going to want to have the pelvic binder on your list of priorities, because basically the only way to survive blunt trauma cardiac arrest is by either stopping any bleeding or by decompressing any air that's in around the heart or in the chest and lungs. And so this is not, most of the time, these blunt traumatic cardiac arrest patients aren't going to respond to medications or electricity like most cardiac arrest patients would. So, consider the pelvic binder as kind of a way to stabilize that area. And there's a chance that it will help to stop any bleeding that's going on. It's pretty unlikely, but there's a chance. If anyone has any questions, I can go ahead and answer them now.
Hey, Andrew, in your video, I noticed they hadn't stabilized the feet and everything. And is there, I don't know if the protocols have changed since I've been in Maryland, but do we do the feet first? I think we were taught to avoid the space between the knees and everything. So this guy was left with his feet, just kind of splayed out like that, which is suboptimal for the backboard.
Yeah. So, if this patient were to be on a backboard, you would kind of want to, you would want to stabilize everything. But what you can do certainly is you can tighten the pelvic binder and then put the backboard straps on. And at that point, you would be able to stabilize the feet wherever you needed them on the board.
Okay, so moving the feet after the binders in place is not a no-no.
Well, I mean, obviously you're not going to want to, have them walking around or moving their feet a lot, but you can move their legs a little bit. Yeah, that's no problem.
Okay, just making sure. Thanks.
So I know we have commercial pelvic binders. Are there any other things that we can use in lieu of a commercial binder if we don't have one available?
Yeah. So for example, pediatric patients where our binder might not fit, we can use a bed sheet or possibly a cravat if they're small enough. But it's kind of ingenuity, whatever you can make work is okay, but obviously the commercial device is preferred.
So anybody that's been in EMT or in EMS, I should say, as long as I have, knows the cravat can be used for very many things. And if you sat through a Charlie Wills class, cravats are awesome. It makes a good pelvic binder. Does anybody else have any questions for Andrew? It's a great presentation.
Thanks. I didn't want to get too into the controversial and stuff, so I tried to kind of get close to it, but not,
Right.
But certainly, like for example, with trauma codes, I think that if you have a blunt traumatic cardiac arrest patient, the pelvic binder is probably the number one thing in terms of importance to forgottenness ratio.
I have a quick question about I don't know, I guess I'll call it the width of the binder. So I actually always wear a cargo belt because if I ever need a tourniquet, I have one. But I feel like that might do more harm than good as a pelvic binder. And I noticed that the device they have is about the width of a weightlifting belt or something. So but then Jamie mentions cravats. So I don't know what the official answer on that is.
Yeah, so if you do use a cravat, you're going to want to spread it out.
Mm-hmm.
You don't want too much force in one area because that's going to put more pressure, like uneven pressure on that already broken bone. The idea isn't to squeeze the bone, it's to wrap the bone and kind of create like an external splint that holds everything together where it should be.
Makes sense.
Any other questions? All right, I will turn off my screen sharing
Awesome.
and turn it back over to you, Chief.
All right. I think Dave was going to. For the paramedics in the group, you guys be interested to see we got a new toy. Well, not a new toy, but an updated version of a toy. Dave has in his possession our new CPAPs. He had to bring it by my house yesterday so we could both look at it because we were all both confused until we figured it out. But oh my God, it is amazing. It is so much nicer. It is smaller. It is compact. It is the best thing ever invented in this universe. And I'll let Dave talk about it. Yeah. If you hit speaker view on your Zoom screen, it'll make Dave nice and big whenever he talks. Everybody else just has to be quiet.
Okay. Well, after that build up, what can I say? All right. So I'm going to get to the right distance here and see if this works. That's about right. So the interesting thing is it all comes in a bag, and anybody who's familiar with the CPAP knows that it's actually the biggest thing, it's the biggest single packet that we carry in our overstuffed packs. And this one, you can see it's about the size of my head, all comes in this bag. Okay. So that's the first thing. And when I first looked at it, I'm thinking we've ordered the wrong thing because it looked like just a mask with a couple of bits in it. So Andrew, have you seen these?
I looked it up, but no, I've never seen one in person.
Right. So it's bipolmidine, which is the same manufacturer as we use on our normal CPAPs. But when we ordered that for replacement, this is what we got. And the answer is because this is now the replacement for the normal CPAP that we use. So the first thing you notice is much, much smaller, about at least half the volume, maybe even less. Things that are easily recognized. So we've got the mask, which is a normal CPAP mask with the clip on the top and the normal spider straps. So nothing has changed there. It's exactly the same. But what is interesting is that, we'll get to it in a minute, is that this fitting on here is the same fitting that we used to, but they use it in an extremely different way to the way that we normally use it. I'll just do a bit closer there. Right. This is a medium mask. The nice thing about it is, and actually, Jamie, this came up afterwards when Jan and I started talking about it yesterday when I came back from our chat. What we've got in mind is we're supposed to carry 2 CPAPs in our bags, and we can barely carry 1. Well, we can certainly carry 2 with these. And
Absolutely.
we're going to get 1 large and 1 medium, so that we don't get into this continuous dilemma of carrying a CPAP and a mask, because the combined size of 2 of these is smaller than the total of the existing CPAP.
Sounds good to me.
Sorry. So how does it fit together? Well, let's look at the parts. I feel like a CNET unboxing guru. This is what your new DVD player comes in. Okay. All right. So first of all, we get a hose. You notice that of all of the things I've pulled out so far, nothing looks like the concertina hose that we're familiar with. So we have a couple of hoses. We have this hose, and here somewhere is honestly yes. Oh, it is. There you go. So we have this hose, which is slightly smaller, and this hose, actually, well, they're the same size. Yeah. So I don't know if you can see that, but this hose, the one on this side, is just a squeak bigger than this one. So this is a normal nebulizer hose, all right? And let's look at what happens with a normal nebulizer. And you're going to go, Dave's going crazy because he's just showing me shit that I know already. So why would I care? So there's our neb, right? A normal neb chamber, nothing special about that. You go onto the bottom, and these things are always double-ended. One end is kind of softish and the other one isn't.
There we go.
You have to be careful not to shear that when you put it on there because it's pretty tight fit. So we've got our hose, it fits on there, and we all know that this end goes off to an 8 litre per minute feed, usually from our normal Christmas trees on the emeralds. Okay, so here's the first interesting new thing. New valve, okay? So we get this thing. So this is completely new. We haven't seen one of these before. So at first glimpse, it looks like a normal, it's kind of strange fitting, right? It's got a DISS connector on this end. So this is a DSISS thread. And this is a short sort of squatty Christmas tree. It also has this, which is a quarter turn on off valve. And just so you know, that's on, that's off, all right? What this is for, okay, you must be transferring to another station. So what this is for feeding our nebulizer, and this is the first big change, our nebulizer, not the CPAP, the nebulizer, by putting the other end, remember our hose here, neb at one end, other end of neb hose at the other end, and that goes onto this stab, all right? And then you would close the valve, or you'd probably do this the other way around, you'd probably screw it on first. But then this goes onto the dish port on your regulator. So we don't connect the CPAP part of the system to the dish port, which is what in the past we've done. So we would have 50 PSI sitting on here, and it's got a regulated 8-ish coming out here. It actually says 6 to 8, but enough to get the nebulizer running. So that's one complete assembly. This is one end of the hose, this is the other end of the hose. So that's the first important point, that you don't expect this to be feeding this. In this system, it does. So let's just put that aside for a minute. And then we're going to look at this, right? This is the rest of the CPAP. And remember I said this hose was a little bit bigger, just a squeak, but it's also, on this end of it, got a marker with 10 liters per minute on it. And that's the next interesting thing. This is the CPAP hose. We don't have one of those corrugated expander hoses where you pull it backwards and forwards. This, on its own, does all of the CPAP work. And frankly, it was a bit confusing, well, because you don't really expect that when you open it up. So you know which one it is because it's got 10 liters per minute on it, all right? And then on the other end, you have what looks like, at first glimpse, almost like another nebulizer chamber, but it isn't. This is your CPAP. This is the whole CPAP system. And the way this works, going back to my mask, is you take your mask, you stuff it onto your patient's snout, okay? put your spider straps on, right? And then you take this and you put it over the outside, not the inside. You used to use this. This goes over the outside of the same fitting. And it goes over the outside of the fitting with this valve. There's a valve sitting right here, a blue valve, that goes down. Okay? And the reason that valve is there, let's go back to our nebulizer, is that this is working as a CPAP, and if I want to nebulize at the same point, all that I do is take my pre-prepared nebulizer and push it into that chamber. And if I break that chamber, it will keep on CPAPing, so I can actually go and refill my nebulizer, come back and push it back in. And when I push that into that system, then I'm nebulizing and CPAPing at the same time. Any questions?
Dave, I have the video from Pulmodine that shows the entire setup queued with you ready, whenever you're ready
Okay,
for it.
well, stand by. I've got one more thing to show you. So now the question on your lips is, yes, but what peak pressure does it peep at? And if I come in for a close look, I'm going to break it away from the mask so you can actually see this. On here, can you see that? You've got 5, 7.5, and 10. And the way that you adjust that, you can see that green disc inside of there, is you just turn. So that would be 5, that would be 7.5, and that would be 10. So just to put a perspective on it, this is your COPD patient with those paper thin, crackly, extremely delicate alveoli and bronchioles, dry, crackly, paper thin, very, very thin. And then if you want your CHF patient and you want to push that fluid back, you can increase up to 10, and that will push your fluid that's in your lower lung back into the patient's interstitial spaces and back into the bloodstream. So when it's all set up, you can start at 5. Obviously, you never start higher than 5. And then you adjust it until your patient gets a degree of comfort and is able to breathe. But you always start at 5 because you don't want to start at your highest peak pressure. Work it up from 5 and see what works. Then that's how the whole system looks when it's finished. Don't forget the other end of these pipes. This one goes to your normal stab. So it's exactly the opposite of what you would expect. This goes to your normal stab set at 10 liters per minute, which is, there's a reminder on there, 10 liters per minute, maximum. You do not exceed 10 liters per minute. And of course you can, even on a normal baby cylinder, you can go up to, depending on your regulator, you go up 15, 25. 10 liters per minute, that's it. You stop at 10. That's working at maximum capacity. The other one, this one with the disc port on it, which is exactly the opposite way around to the way you would think it would be, goes onto your disc port on the same regulator, and then you switch it on to nebulize. Okay. Any questions? For those that are more technically minded, this is delivering 30% FiO2. Okay, so 30% FiO2, which means that because we're working at a lower pressure, we've got, and a smaller hose, your bottle is going to last you significantly longer than it did with that big concertina hose. The whole package is, the medium size is actually 10% cheaper than the old model. The large face side is about the same price as the old model. but all of them are going to change to this. We have 2 of the old orange models left in the storeroom. Appreciate if you could use those first. And then once those are used, either that will dump them to DES. And at the moment, we've got 3 of these in here in our stock. And what we'll do, I've already asked Jan to order a batch of 5 of the medium and 5 of the large, and then we can have a large and a medium in every one of our airway bags. Okay, so now you don't have to get into that dilemma. You can go in and get the right size for the patient. We will make sure the bags are very clearly marked as to whether they're large or medium. One last thing, and then Jamie wants to show us a video, is that we have some new bag valve masks. And for some obscure reason, the bag valve mask manufacturer has managed to think it's a good idea to supply those bag valve masks in cardboard boxes. The exact words on my lips after the rude ones were, "What were they thinking?" Right? And that's what it looks like. Right? It's like something out of Sensi as opposed to something that you'd want to bag valve mask in. But what we're going to do is we're going to unpackage these bag valve masks, and we're going to use our big vacuum pack strips, and we're going to vacuum pack the new bag valve masks into these, which will crush them down and make them more compatible to putting in a bag. So don't be surprised if you see these, but by the time you get in there, you'll probably see these, and they'll be crushed down into a vacuum packed container. That's it. That's all I've got. Jamie, you've got a video, I think.
Yes, yes. This is the training video from Holmadine. Wrong screen. Hold on. Here we go.
Welcome to the new and exciting video introduction and in-service of the GoPap disposable CPAP system. Let's begin by discussing the basics of our GoPap.
The GoPap is a fully disposable CPAP system that's manufactured in America. It utilizes the low pressure port set at 10 liters per minute. Unlike other disposable CPAPs on the market that use the low pressure port, our GoPap's PEEP settings are independent of the flow. This means that you can set it and forget it and focus on caring for your patient. There's no need to mess with manometers or continue to crank the flow up to higher levels. At 10 liters per minute, our GoPap will run up to 90 liters per minute of flow to your patient at 5, 7.5, and 10 centimeters of PEEP. Our device is made in America. Some might overlook this, but this is a great point to make as we create everything here which decreases shipping times and assures you that you are getting an American-made, well-tested, FDA-approved product. Every piece is touched, inspected, and tested by human hands.
The GoPap comes with the BiTrack ED mask, and it comes in 2 sizes, large and medium. Medium is the most popular size and will fit about 80% of your patients. The BiTrack ED mask is a floating mask and is designed to fit on the patient comfortably. When we tighten the mask, we don't want to over-tighten it. Over-tightening the mask will create leaks. And in fact, if you're experiencing leaks, it's actually better to loosen the mask and not tighten it further, as we're used to in other CPAP systems that you may have used. It is made from silicone, which will enable you to get an effective seal in the pre-hospital space. And it has an adjustable Omni-clip on the forehead to enable you to get a perfect fit. The straps on the outside are fully adjustable and can be secured using the Velcro once the patient has accepted the mask. You will also find with the BiTrack ED mask that you will be able to use nasal cannulas and capnography without affecting the seal.
So by now you're probably thinking, okay, you really haven't told me anything that makes this different than what I'm currently using. Well, here you go. It simply connects to the low pressure barb. You turn it to 10 liters per minute. You do not exceed 10 liters per minute. You set the PEEP and let it work. The PEEP is independent of the flow. You never have to adjust the flow to increase or decrease the PEEP pressure, which is the case in other devices. Plus, the flow is up to 90 liters per minute with an FiO2 of 30%. No manometers, no charts, over 40 minutes of runtime on a full D tank.
The GoPAP comes with an integrated nebulization port, which is standard on all devices. It's a closed system until the canister is inserted into the device. Circuits have the option of coming with or without the canister.
Now, a full demo of applying and operating the GoPAP with Neb.
The BiTrack ED mask comes in its separate bag. Once you've taken the BiTrack ED mask from the bag, the GoPAP will fit on the hub of that mask. The end of your O2 tubing will fit onto the end of the GoPAP. You will then need to connect your O2 tubing to the low pressure port. After you connect the oxygen tubing, you will adjust your flow settings to 10 liters per minute. Do not exceed 10 liters per minute. Once you feel the flow come through the mask, you are then able to place it on your patient. We would recommend giving your patient time to adjust. Have them hold the mask to their own face. This allows them to ease their anxiety and to feel the oxygen at their face. At the top, place the straps up and over the patient's head. You will connect the mask at the bottom using the clips. Once you've placed the clips on either side, you will pull the Velcro to tighten the mask. Do not tighten the mask too tightly. Tightening the mask too tightly could create leaks around the patient's face. Our mask is a floating mask, and it is created to float on the patient's face comfortably to create an efficient seal. One thing to note is that our mask has an Omni-Clip feature. This allows you to move the mask in and out and up and down to fit your patient efficiently. Our GoPAP comes with 3 PEEP settings. This PEEP, as stated prior, is independent of the flow in the tank. 5, 7.5, and 10 centimeters of PEEP will run accurately with 10 liters per minute of flow. If you choose to nebulize your patient, simply connect the supplied O2 tubing to a second oxygen source. Place your medication into the canister. You can use the top of the canister or the needleless entry port. Set your flow to 8 liters per minute. Once you see the flow of nebulization from the top of the canister, place the canister into the circuit and give it a slight twist.
In conclusion, this product is a simple approach to
It doesn't get much more after that, but they also have, if you look, they have a picture, like Dave was saying, that you can hook the neb up to the same tank as the thing, and I gotta see if I can find it. It's, they had a picture up here. I'll have to look for it. I'll show you guys later, but where the nebulizer actually hooks into the same bottle as the O2 with that other port that Dave was showing you, and it has an on off switch, so you can turn it off or turn it on depending on what you got.
So, you know, my final comments on this are, anybody who has had a really, really serious COPD patient or a really, really serious, actually, CHF patient, it's very, very important to be able to put this on quickly and efficiently. I think the worst I've ever seen is I'm quite sure they would have coded if I hadn't got that on within 30 to 45 seconds. So it's very important to go through this particular training because you don't want to get to a point where you open a bag you've never opened before, and then suddenly once you've opened it, you've got all of these hoses that you're not familiar with, and you don't know what you're doing. So by the time you've got 2 or 3 minutes into it, you've got a coded patient. You don't need the CPAP anymore. So I strongly urge anybody that's going to do this to be there to do it. BLS providers, even though you can't apply CPAP in Maryland, very important that you are ready to help during this process. Somebody who is absolutely have circled the drain and they're about to go down the plug hole is fighting for their life. You literally have got somebody who's drowning in their own fluids. And helping the process by making sure that the parts are there, nothing gets dropped, nothing gets missed, helping to fit the mask to the face, never put the mask on unless there's oxygen flowing through it. The worst thing you can do to a drowning person is cover them with a plastic bag and hope that they're not going to fight some more. So it's really important to get the sequencing right. ALS providers, if it's a COPD patient and you're going to throw some nitro down their neck, you know, it's literally almost one movement. Nitro, well, actually, first, you would want to put entitled CO2 on. So entitled CO2, nitro, CPAP mask, strap it, control them with your voice until they've got comfortable with the process. And getting that muscle memory to do all of that very quickly and smoothly is the difference between having a coded patient in the back of your ambulance and a patient that you've got a chance of, by the time you get to the hospital, they can actually talk to you. Any questions? Okay, thanks very much.
Definitely a heck of a lot easier to put together than that random bag of parts that I have to carry something in my pocket all the time so I don't forget it. So I'm very, very impressed and happy. Lastly, if you guys didn't see the email yesterday, we got our new tablets, right? They've been installed in all the units. For the love of God, please don't break them. Don't drop them. I'm looking at you, Katie. Yeah, please be careful with them. You know, make sure that you know how they go in and out of the brackets because it is a little different. The mounting brackets because it is a little different than our old tablets. They are smaller, more lightweight, but be nice to them for a little while at least. Okay.
$5,000 a piece. Okay. So just bear that in mind when you're handling them.
Yes.
And when you're handling them, putting them in and out of the dock.
Yes.
You know, you use some. We don't need to be gorillas. Just gentle, thoughtful motion as opposed to beating them with a big stick.
Exactly. So they're very nice. They work great. And everybody has a keyboard now. So no matter what unit you're in, when the tablet is docked, you will be able to type in using a keyboard, which makes your life so much easier than doing the chicken pack on your screen. So, and I think